Yeah, confirm you can listen. My name is Osuji Dan.
Thank you, my colleague. Was coordination, especially when members of this story that we find around there. The minister was able to one of the think tank of the administration. So he's been in there, so most of it is that taken by Mr. President.
Yeah, confirm you can hear me from your end. I want a response so that I can link up properly. Special advisor. I think it's a good decision from the minister this is still an economist department has done before. There's been in all these sectors. Exactly. I think you have very good yes. I get what you think. But I'm for instance along with millions of Nigerians. I don't want to pay as much as I am paying for a liter of fuel. But as as Mr. Lafayette just said, that will be dependent on that. We need to be very, very patient. We are really hard to be not overnight, and we will not be really overnight. And we must know that consider in this instance, the expert that because of the amount of supply that everybody. It's also to consider to definitely these acts of leaders. So when you look at that, a major challenge for policies in the area of supply, not the demand, but demand on the supply side. Whereas this is not look at supply, there are four major areas that we can supply. We look at the for gas, and the diaspora, we look at our setup for look at foreign direct investors, investors. Look at assistance that we need to see those pieces of the thing that is what we transfer abroad. How we going to work for the industries to make sure that we have those dollars coming that into our economy that being peace of mind. Those are part of what we will work on. So this that the CPN when you that somebody has requested to what I have said. Audio is bad. Host, kindly fix it. Host, kindly fix it. this challenge because that seems to be that with morning prayer, society will come existed. But now I believe that we are one day from see the physical side from policy that we will select the monitoring, for example, all is very monitoring policy and physical policy to have the same agenda. When your agenda as a physical policy is to make sure that people, especially employment trades, businesses, are able to enjoy native, maybe not too much, but business are able to strive for some side of the make sure that what they have that's what I'm thinking. Yeah. But we will not see that we see not for the citizens independent. You will need to do what the city will what you want. You do what's there, decide what's there, then you see that city.
I want to tell my better. I'll go and buy this stand.
Yeah, right, the second cost for the most you need to do the physical side that generally down. When you talk about physical side, what are these things you need to look at the cost of living itself. You need to begin to talk about how you can reduce the economic cost. They are not having type of the best cost we want to have. Those things just achieve overnight. It will be
Sometimes.
Are you listening to them?
It's not sure that the line of down at the bank of that I can go in there. We have often because that the way we come into Nigeria and what conversation share number because you never know how long the thing is going to last in Nigeria. What do you think about that? Well, let me start by saying that foreign direct investment thrive on equal factors are very important. I need to talk about one is that the piece of business is very important. Investment. You have to work with ID businesses. Number two,
paying special attention to the age of client patients, the location of the and others. Knowledge of common shoulder disorder is as important as they can often be treated with conservative measures. Shoulder pain is a common musculoskeletal condition that is recognized as a saving problem and treated with the pain and disability associated with shoulder pain can have a large impact on individuals and their families, and their participation in social activities or leisure programs affecting daily functioning and ability to work. It is the third most common musculoskeletal complaint presenting to physiotherapy. The extent of tissue damage observed on clinical imaging doesn't correlate with shoulder pain intensity. Thus, the relevance of diagnosing structural pathology with people with shoulder pain has been challenged in many research and clinical practices. For the anatomy, the shoulder joint or glenohumeral joint is a ball and socket type synovial joint and one of the most mobile. It is formed by articulation of the head of the humerus and the glenoid cavity or fossa of the scapula, which is behind. With a loose joint capsule only allowing a limited interface of the humerus and scapula, it allows for more axial movements. The glenoid cavity in itself is quite challenging the humerus to fit in a cartilaginous fiber known as labrum along its axis. A glenoid labrum which deepens the fossa. To explain further the dynamism of the shoulder joint, it is common you have the joint capsule. The joint capsule serves as a fibrous sheet which encloses the structure. It extends from the anatomical length of the humerus or to the leg cavity. The joint capsule is light. The little greater mobility, particularly in the synovial membrane lines the inner surface of joint capsule and produces synovial fluid to be friction between the articular surfaces. Ligaments. The ligaments play an important role in the life of the joint. The ligaments, the middle, superior, and inferior. Reinforcing the joint capsule. We have to stabilize the anterior aspect of the joint. Process of the scapula, forming an arch-like structure over the shoulder joint. This resists superior displacement of the humeral head. The bursing. The bursing is a filled sac which acts as a cushion between tendons and other joint structures. There are several bursings present in the shoulder joints. You have the subscapular bursa, the subclavicular bursa, and the subacromial bursa. The muscles. These are the primary stabilizers of the shoulder, including the biceps brachii, which is the arm, as well as the rotator cuff muscles and the tendon which sits on the humerus. The tendon of the long head of the biceps brachii passes through what's known as the bicipital groove and inserts on the superior margin of the glenoid cavity to press the long head of the humerus against the glenoid cavity. Other long muscles, such as the pectoralis major, the latissimus dorsi, teres major, and deltoid muscles, provide support to the shoulder joints. The tendons of the rotator cuff muscles and their respective muscles stabilize and fix joints. You have four of them: the supraspinatus, the infraspinatus, teres minor, and the subscapularis. Movements. Now, the movement at the shoulder joints go in different phases. First, you have what's known as extension. I'll change my position this way. My arm moves up. This is known as extension, taking your arm behind you. The next movement we have is the flexion, taking your arm forward in front of you. Then we have abduction, taking your arm away from you. Now, the first 15 degrees is supported by the supraspinatus muscle. The middle fibers of the deltoid are responsible for the next 15 to 90 degrees. Then, at beyond 90 degrees, going to 120, the scapula needs to be rotated to achieve abduction. So the trapezius muscles behind the serratus anterior muscles amplify. Abduction, taking the upper limb, taking the arm towards the body. You have the pectoralis major, that's also anterior major. Internal rotation, rotating the arm towards the body. This is responsible, this is from the subscapularis, the pectoralis major, maximus dorsi, teres major, as well as the anterior part of the deltoid. We have external rotation, taking the arm away from the body, so that it comes pointing outwards. You have the infraspinatus and teres minor. Then circumduction, moving the arm in a full circle, either clockwise or anti-clockwise. Epidemiology of prevalence. Shoulder pain is the third most common cause of musculoskeletal conditions in primary care. The prognosis for people presenting with musculoskeletal shoulder pain varies between individuals, with on average 50% of people with shoulder pain still reporting symptoms 6 months after presenting in primary care. The incidence range from 0.9 to 2.5%, with an average incidence of 29.3 per 1,000, with specific incidences of 32.2 for women and 26.2 for men, according to an article done by Brandon in 2021. The incidence of specific conditions, rotator cuff tendinopathies, incidence from 0.3% to 5.5%. Traumatic dislocation of the glenohumeral joint is the most common joint dislocation, with an incidence of 8.2 to 23.9 per 100,000 every year. Now we move to the predisposing factors. Predisposing factors are risk factors that could lead to a possible condition, where you have constant or repetitive motion of the arm in the event of the overhead activity, like I mentioned, athletic activity. Let's say a tennis player or someone who plays volleyball, repetitive overhead motion. You have chemical factors such as systemic diseases, including diabetes mellitus. Social demographic factors, it tends to affect women more than men, and tends to affect people beyond 60 years. Personal factors, where you have obesity, posture habits, lifestyle habits like smoking or alcoholism. Occupational factors such as heavy lifting, pushing, carrying, and overhead or over shoulder activity. Other factors include joint laxity and instability, psychosocial factors such as traumatization or anxiety disorders. Causes. Shoulder pain causes include a vascular necrosis, where you have alcoholism and steroid intake, leading to high levels in the blood. As for alcoholism, it tends to reduce or constrict blood vessels, limiting blood supply to the neck, to the head of the humerus. Peripheral nerve injuries, such as axillary nerve compression, people have to use crutches, maybe given the lower and they have assisted devices. Fracture dislocation also happens. Otitis, frozen shoulder or adhesive capsulitis, heart attack, impingement, osteoarthritis, rheumatoid arthritis, rotator cuff injury, septic arthritis, sprains, tendinitis, tendon ruptures, particularly of the deltoid or long head of the biceps, thoracic outlet syndrome, or torn cartilage. The torn cartilage, two types particularly, the SLAC or superior labral tear anterior to posterior, and blood, the glenohumeral muscular dystrophy. Signs and symptoms. Now, most common presentations for patient can be regarding shoulder pain. You have pain or pointed tenderness. You have a limited range of motion, inability to maybe raise the arm or move in a certain direction. If here avoidance, avoidance just means due to the fact you know the pain gets worse, it limits the entire movement of that area, which in turn is not good because joints, like mostly, are supposed to move. You have swelling, you could have muscle spasm, you could have weakness of the arm, comparative weakness. You see the other arm can do certain things, the other arm that is affected now can't do. You have body asymmetry. You have possible numbness or paresthesia and compensatory movements. Let's say the events you can't take the arm away from the body, you ask the patient to wear a jacket. You see them trying to just snuggle in and force the arm without having to take the arm away from the body. The diagnosis. You have various forms of clinical imaging. And like I previously mentioned, clinical imaging doesn't necessarily correlate with the intensity of shoulder pain. The clinical imaging are going to be usually X-rays, MRIs, CT scans, then physical examinations, where we have observable joint asymmetry, where you check for the extension, either the scapula, I'll be demonstrating some. If you test like the apprehension test, O'Brien's test, Hawkins-Kennedy test for impingement, the SCARF test, Jones test, Yerkeson's test, or Nair's test. Now, with the most commonly seen conditions, I highlighted a few for shoulder pain. Osteoarthritis, avulsion, tendon injuries, fractures, glenohumeral instability, or rotator cuff tears. And I'll take them individually. For osteoarthritis, known as a degenerative change to the joints, most presentations usually include pain, stiffness, swelling, bone spurs. By bone spurs, they are clinically called osteophytes. And these spurs, they kind of limit the movement of the shoulder, to which a clinician will notice if you actively tend to move in a particular direction. They could hear grinding sounds, not snapping sounds, grinding sounds, like something is rubbing hard and giving creaky sounds. And a grating sensation, like I just described, a creaking sound. We have rotator cuff tears. Most commonly presented are the patient will tell you, I can't sleep in the night because when you turn to one direction, it really spikes up. Or arm weakness, you can't move the arm as much as the intent. They reduce range of motion, given there's an injury there, they don't want to move it at all. Or a dull ache deep in the shoulder. Or glenohumeral instability, you have the clicking sound. Now, the clicking sound is more like when you perform a movement, yes, small sound, click, 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 not a grating sound. Now, the complaint of down throwing, we actually have a patient he just started. When he throws hard. Now, given his injury he sustained not so long ago, he has noticed he can't bowl as hard as he used to and has avoided bowling entirely. You have bigger capacity to then avulsion tendon injury. You have pain, limited range of motion, given and also tendon is removed from where it's supposed to be. Invisible deformity, including discoloration. So, each condition, you have specific tests to rule out the possible injury. And also, with your X-ray, you see narrowing of the joint space between the humerus and the scapula, the acromion part of the scapula. We also have spurring or crepitation when you try to move, and a limited or restricted range of motion. Certain times with an arthritis, you can also have joint effusions. Joint effusions are minimal swellings that are around the joint, making it tender to touch. Rotator cuff tears. You have a positive lateral Jones test. With the Jobs test, you ask your patients to stand, then lift their arms to 90 degrees, extend to about 30 degrees, then tell them with your thumbs pointing upwards, go downwards. Now, in doing this, you're sort of rotating the arm under a region known as the acromion. In the event of a positive sign, when you rotate inward, they instantly tell you the pain there. When you do an rise test, you do the rotation inward with a depression on the wrist, while telling them to resist that depression. With your rotator cuffs here, the symptoms also include pain with overhead activity, maybe throwing or trying to lift a book and place on a higher shelf, or some in-house activity, night pain, weakness, or a painful arm. Here would show a lot of acromial mention, internal or acromial spurs. Now, for frozen shoulder or adhesive capsulitis, you have a decreased active and passive range of motion, especially external rotation, taking the arm outward. With a frozen shoulder, you also have to check for a history of diabetes, mobilization, or the clinical investigations to identify the frozen and MRI image, because an X-ray will show normal findings, but with an MRI, will see injury. The symptoms are a significant level of pain, limited shoulder range of motion, without displacement visible, weakness of the shoulder and shoulder asymmetry. The MRI findings will reveal a tendon discontinuation, while X-ray images will be normal. With a fracture, you have visible deformity, abnormal alignment of the shoulder. Pain works with movement and tenderness and swelling. As for the radiograph findings, you have visible bony discontinuation in clinical imaging. MRI or CT scan will show more structural involvement. For the glenohumeral instability, you have a positive apprehension test. One or two tests will do to show sort of indicate what kind of injury is present. For apprehension test, I'll be getting a subject to demonstrate what it looks like. So you have findings like a subluxation or a sulfur sign and generalized ligament laxity. The X-ray imaging will show a normal. Now for the physiotherapy management. The current evidence suggests that conservative management is often effective for treating various causes. Conservative approaches are typically the first line of treatment before considering more invasive options like surgery. Our practice as an organization in this regard will focus on employing conservative approaches to manage shoulder pain and enhancing functionality, addressing modifiable physical limitations whilst looking at a timely resolution of independence and wellness. Now, in terms of physiotherapy management, education is important. We have to inform patients as to understanding the condition, the treatment options, and self-care strategies, because it is patient-centered. Additionally, informing patients about ergonomic practices, lifestyle modifications can aid in preventing future issues. Effective communication can empower patients to actively participate in their recovery and make informed decisions about their health. Positioning. Now, for positioning, it will be a bit demonstrative. So for the positioning class, supporting the sore shoulder can help reduce it. While lying in bed, it is advised to lay on the opposite side of the knee. Laying facing behind and holding a pillow with the sore arm, which can prevent rolling onto the sore shoulder, which will limit the chances of landmine pain. Give me a minute, I'll be describing that. And alternatively, if not lying on the back, alternatively not lying face front or on the side, lying on the back with a pillow under the affected arm may help support the shoulder. I'll be demonstrating the positioning part with lying down much later. As for sitting, when sitting, it is important to be comfortable with the arm resting on a pillow or a cushion in a relaxed posture. Thank you very much. All right. Now, for the positioning part, let's say in this instance, we have the shoulder being on the left arm of the subject. What I'll ask is, please, can you turn to your side? Now, imagining there was a second pillow. This pillow behind him, to limit on the body behind, while you have another pillow in front of him, you also place the arm. Let's take this to the right of it. Now, with this, the arm is fixed in position, while the pillow behind, limiting any chance of rolling backwards. Now, the other part is yes. The other part is placing the pillow under the arm. Placing the pillow in this direction. Basically, you're resting the upper part, of the arm, the elbow along the pillow. Now, in doing that, you limit any chance of possibly rolling to this affected side in the event of the pain being on the right side. Now, it differs for sitting down. Please, can you stop? So, when sitting without boundaries, maybe sitting without an armrest, it is advised to raise the foot under the elbow, basically maintaining shoulder symmetry, as well as limiting a drop of the shoulder joint. With a grounded chair, it will be a lot easier given it has a frame, and your advice is sit back and rest both arms on the cushion. For pain management, the pain management styles vary. You have the thermoregulatory part of pain management where All right. Other pain management methods also include exercise therapy. Now, exercise therapy is not a standalone. It's supposed to be combined with other forms of management. You have progressive exercise or resistance training. Let me give an example. Over here, we have a 3 kg and a 4 kg dumbbell. Now, in the event it's a condition maybe involving external rotation or abduction. Given the assessment that has happened on the first visit, we assess the muscle power and strength and what they can do in terms of function. Now, with progressive loading, you see how it translates from trying to lift said area or move said area either against gravity, if they can allow that, or moving with a resistance, in this case, a 3 kg dumbbell. Now, I'm going to demonstrate just across the other arm, and apply a bit of pressure at the base of the elbow, just inward like that. You have functional or self-care assessment, e.g. grooming, maybe combing your hair, or applying roll-on. Now, these things may seem simple, but to people who have these concerns and have lost their reasons for that, it is a target that we would like to get. Recently had a patient who has an avulsion tear of his deltoid. It was a great relief to him after a couple of sessions, and he was able to raise his arm to 90 degrees. He even told me, yeah, look at it, I can now apply my roll on myself. Other things included are maybe being able to drive. Let's say you get to your roundabout and you're having to turn. It involves a lot of arm movement. You notice an arc. Other suggestions on exercise therapy advises to indulge in appropriate recreational activity, particular to one's interest. So, as a physiotherapist over here, we would tailor your exercise programs long-term into interests that you are more familiar with. Let's say you are the tennis ball player. We would look towards getting you into arm swings and if possible return to tennis as a repeated activity with monitoring on the shoulder pain concern. Others also include swimming, skipping, given the for as well as table tennis. Furthermore, in 2020, and Smith et al. Of exercise-based interventions in reducing pain and improving shoulder function. These findings reinforce the value of evidence-based approaches in guiding clinical decision-making and making treatment plans. Manual therapy. This is more effective when used in combination with exercise. Manual therapy refers to manipulation in low amplitude, high velocity movement at the limits of joint range of motion that takes the joint beyond the passive range of movements. It encompasses the utilization of a hands-on technique with the intention of therapy and appears to provide advantages to certain individuals experiencing shoulder discomfort. Its effectiveness seems to be enhanced when paired with exercise, making it a viable option for success. Manual therapy examples include the anterior posterior glides, inferior superior glides, posterior anterior glides, lateral glides. I'll be asking for a subject so I can demonstrate just one of said glides. Now, an inferior anterior glide would be you getting the patient's arm across and then supporting the shoulder joint and driving downward. Now, in his own case, he does not have a production of pain. The joint is normal. But in the event you're trying to treat, this is one of the glides. Just drive inward and inward and come back, inward and come back. Another is to, while standing this way, back the patient, then place your hand just at the top level of the humerus on the inner border, and then pull outwards, more like in a rotatory manner. This is the lateral glide. You also have nerve stimulation or functional electrical stimulation, which serves as an adjunct to treatment to strengthen muscles, decrease pain, and curb inflammation. In the ever-evolving landscape of healthcare, the integration of evidence-based guidance remains pivotal. As we strive to provide the highest quality of care to those suffering from shoulder pain, we at Amazing Physiotherapy Clinics will continue to leverage on these guidelines as our compass, ensuring our interventions are firmly grounded in the best available evidence. In conclusion, our adherence to evidence-based guidelines in providing optimal care to patients. Our adherence to evidence-based guidelines is essential in providing optimal care to patients or individuals coming to any of our facilities on account of shoulder pain. And by integrating these evidence-based approaches into clinical practice, we can enhance patient outcomes, minimize unnecessary intervention, and contribute to the overall well-being of those seeking relief from shoulder pain. Thank you for your time. Do you have any questions? Please send me your questions. I'll be here to give answers.
Shamsi Ajiam said, thank you for your time and lecture.
Thank you. Thank you, Sam. Really appreciate your time and listening. Your question. Okay.
Someone asked a question on TikTok. I slept and woke up with shoulder pain on my left side. On the side, I like sleeping. So, what could be the possible cause and what do I do about it now?
A 2-day onset. Thank you for the question. A 2-day onset is in the range of an acute condition. Really sorry about the pain. Now, we would like to ask a number of things in terms of how intense it is. Does it limit your day-to-day activity? Given you just noticed it 2 days ago, is it restrictive? Have you noticed, okay, maybe you can't drive or maybe cancer items? In terms of what you can do about it, it is you see the intensity of the pain. We usually operate on the visual analog scale, with a rating of 0 to 10, where we say 0 is no pain, or the lowest level, and 10 is the maximum, most imaginable pain. I would like to ask you to maybe review your pain concern to see how high you score it. Anything beyond a 3, I would suggest you visit our facility so we can have a physical assessment of this. With a physical assessment of this, we could easily tell you how serious it is and possibly offer you the lines of treatment for that. Thank you.
Okay, another question. How can I register? Is it monthly registration or annual registration?
Now, in terms of registration at our clinic, it is when you visit the facility and we assess you. The assessment will cover everything you tell us in detail regarding your history and lifestyle habits. And in turn, it will better inform our decision as to what would best serve as a plan for you. Thank you. More questions, please. Keep them coming in. Imagine having shoulder pain and not being able to go for this activity, go and bed. Think about it. You can't tie your guinea because it's an overhead activity. Shoulder is hurting. It's not fair.
Okay. Someone said, fantastic presentation. Thanks to
Thank you.
Daniel.
Thank you very much. Ooh.
Can we be getting more health information in our mail?
Oh, yes. We have monthly newsletters that we send. Oh, rather, weekly newsletters we send. We just need you to provide us with your email address and you become one of our subscribed lists to get said information. Thank you for that. More questions? More questions? No, please. Basically, ask it for. Let me read out this.
Okay, and a friend of mine said that they have been experiencing shoulder ache on the left shoulder since a year now. That when he tried to lift the hand in full range of motion, he feels the pain at the injury. So, but on the normal, when he tries to do a little movement, he doesn't feel the pain. Yes, yes.
Okay. Well, here's the thing. Given it has lasted, given the pain concern has lasted over a year, first we would normally ask the history as to what led to said pain concern. If he recalls anything within that 1 year period that he started doing that likely triggered it, then possibly find out his intervention or methods he has used to manage it. Now, given the pain concern is now limiting enough that at the end range he can't do certain things, it means that his maximum reach he can't function. On the maximum reach, it means when you get to feel the pain on maximum reach, you can't do any overhead activity that you probably tended to do before. In some cases, it could be something as simple as doing home chores over the weekends, reaching for shelves. Now, given this pain concern, like I previously said to the other questioner, on a scale of 1 to 10, make a mental assessment when you try to move in that direction. Anything exceeding a 3/10, please, I would advise you come to our facility. You will be properly assessed and given the best of care in terms of the plan and how to manage the condition. Really sorry about it. Thank you.
So I have a question for Mr. Brown. How can we contact?
Oh, in terms of contacting us, we have at least 7 branches across Nigeria. 4 in Abuja, where you have Wherever Wuse, Gariki, and Zakania. 1 in Port Harcourt, the D line, and 2 in Lagos, 1 on the mainland and 1 on the island. We have our contact numbers available to each of these branches. You can call any number and you'll be quickly referred to best possible line of care. Thank you. Please, questions, please.
Someone sent a question, and the question is, what are the common household causes of shoulder pain?
Household causes of shoulder pain. Thank you for the question. Now, this will vary with activity. Some of the possible causes are a fall on an outstretched arm. Let me give an example. Suppose within the house, somebody mops an area and doesn't put a caution wet sign. The person goes and slips on it and falls down. With the outstretched arm, there's the possibility of risking shoulder damage, given you try to break your fall with the arm. Another cause could be maybe an unnecessary tug. This, I actually thought about this yesterday. In the cases of grandparents visiting their loved ones and maybe encountering their grandchildren, you could have an overly enthusiastic child tugging on grandma or grandpa, which would lead, in that instance, maybe present humeral instability or laxity. It could lead to a subluxation of the shoulder, given they are tugging downward, and that region is not as strong. You could also have long-term injuries with assault from an unwanted individual. be a postural representative word use, especially in the instance where a person is not as active, doesn't work out as much, and tries to do certain exercises over and over again. One common one would be using a broom to sort of sweep overhead. This is common among people who do household chores, particularly have continued sweeping motions leading to a possible shoulder injury. The only thing is that the extent will vary with the level of damage at that region. A clinical finding or a physical assessment, one of the physical tests we do, will better identify to what extent the injury will be.
Okay, I have another question. I have a friend who's a basketball player. Whenever he plays, he sustains, he usually experience a dislocation of the shoulder. This has happened 4 times now. So he discovered that it happened, he had just pain at the shoulder, and the pain has not really gone down. He's been there and he has been expressing it, and it's very painful. He cannot abduct the arm fully. So I don't know if
Word.
yeah, about
Okay.
it.
Thank you for that. Like I mentioned, one of the causes of said injuries are athletic activity, especially overhead or over the shoulder. For a person already suffering continued dislocation of the shoulder, you have really serious ligament laxity. Now, the question would be, given the first noticed it on one occasion, what was the line of management at the time? Most of the time, we have patients coming with self-concerns. I even had one that recently came into our OC branch on account of trying to throw a punch and his arm pulled away until it was relocated. Now, the best line of management would be a combination of what I previously mentioned, educating them on the importance of strengthening and physiotherapy. Now, in the event you have ligament laxity, it's first to see to what extent. If the arm is too loose, or it provides what they call a sulcus sign. A sulcus sign is an assessment where we distract the arm to find out whether the deltoid leaves an impression. If the impression is large enough for the thumb to fit, it's positive as a sulcus sign, which in itself is not good. Now, in that event, you would be advised to consult a physical therapist, which is our service, to first assess how bad it is. Now, in terms of treating for a short period, depending on the level of injury, you may be advised to probably reduce any overhead activity. In a few cases, it could just be a couple of days, depending on severity, maybe a few weeks. But in that timeline, you are not just stopping the activity and not doing anything. No. You're being managed for the pain test, being managed for strengthening programs to better prevent a chance of a possible dislocation. And maybe after a couple of weeks, usually between 3 to 4 weeks, you'll be advised to return to low-level physical routines. Like I mentioned, certain recreational activities tailored to your interest. In the event of an overhead activity, you could be advised to go learn other swimming strokes to better move the shoulder within certain range of motion. I hope that answers the question. Thank you.
So we have a comment someone great job.
Thank you. Yes, thank you so much.
So another question I got is, how long does it take to start seeing like a typical shoulder pain? How long? So because the person said his uncle has been having for pain for a long time and tried treatments. So and nobody wants to tell them how long. And they diagnose the uncle of potato cough injury. Yes, and you want to know exactly to be certain how long it normally takes for typical potato cough injury to find so that they can make plans.
Thank you for the question. For rotator cuff injuries, we also have to factor in the age of the patient, the level of activity they exhibit on the day-to-day, at least for the last 2 to 3 months. Now, this better informs us as to that, but typically, depending on severity, a rotator cuff concern, while managed at any of our facility, usually results within the first 3 to 5 weeks. In that timeline, it will depend on the frequency of visits, the interventions given, as well as the patient's willingness to cooperate, which in no short measure is necessary. Thank you for that.
Okay, we have a couple of questions here. This one from Daniel Suji. I have had 1 year persistent shoulder pain, most while sleeping. No injury before then. Once I turn on bed, it's more severe. Your thoughts?
Okay, I'm sorry.
Okay, and again, he said X-ray did not reveal any abnormal disposition. My worries.
Okay. Sorry, Mr. Daniel. I'm really sorry about that. Given it affects your sleep and it has been for a 1 year period, no findings on the images, it will likely be a muscular concern. In our facility, like I mentioned, we could run a couple of physical tests where we get to move your arm in certain ranges to see what particular structure may be affected. Like I mentioned, there are 4 particular rotator cuff muscles. All rotator cuff muscles have specific movements to either indicate an impingement or a tear. The particular ones, the most common ones you get to see would be an empty count or a Jones test, or you could have a Mears test, that is what it's called, or you could have just a lift off. So in said events, I would suggest, if you can make it, to either of our facilities, please come over for a free assessment. There we'll be able to better tell you what we can do in terms of a plan of treatment. Really sorry to interrupt your sleep. We do hope you can trust us with your management. We'll get to show you the better style of it. Thank you.
Okay, we have another question. Someone had a chronic shoulder pain post-total following AVN in background of SCD. There is limit ROM in all planes, but abduction and extra rotation movement are more limited. What are your thoughts?
That is from the most significant concern. My honest opinion would be, if you can, please make it to our facility, given the limits in range of motion and the history of the SCD, as well as the fact that it has degraded into vascular necrosis. We would advise you come to the facility as fast as you can. There, any of our qualified physiotherapists will better assess you and tell you the options for treatment. I'm really sorry about the inconvenience. Do hope we can make it to our clinic. Thank you.
Yes, somebody asked a question on TikTok again. The person said, this TikTok people, I don't know. But the person is saying that can shoulder pain affect someone's sexual life?
Oh, definitely. Please, let us not make light of pain concerns and how they affect our day-to-day. Shoulder pain can definitely affect performance, given certain sexual acts involve different positions of both partners. And in the event that is an issue with wearing one's weight on a particular shoulder, it could further affect the drive to want to engage in said sexual activity, which in turn could accelerate and become something of a psychological stress. Really sorry to whoever has that concern, but rest assured, like I mentioned, there are many forms of intervention we can employ in managing it. Please, shoulder pain should not be limited to enjoying one's self to the maximum. Really sorry about the concern. Thank you. So, at this juncture, I would like to thank you, the audience, for your time. And I hope you can make it down to our facility one day, gradually or with intent. Please come to our facility. We will give you the very best of care. We recently won the award for the best physiotherapy clinic in Nigeria. So we are not bragging when we say we are the very best at what we do. Please come on down and we'll improve your lifestyle. Thank you.
Okay. Did you hear the question?
Credit shoulder pain, how soon can we do this in a couple of months?
Shoulder and neck pain going on for years, and I'm making therapy. Cure it within 3 months.
Okay. We just recently got a question about a person suffering from a shoulder and neck concern lasting for a couple of years and asking if we can resolve it in a couple of months. Now, like I mentioned, these concerns are varied and we will need a proper history of the concern and its lines of management. Really sorry about it lasting a couple of years and affecting your lifestyle habits. Well, what we would advise would be, please visit any of our branches. At any of the aforementioned branches, we tend to Nigeria, we will better assess you and give you the best of care. I can't tell you a duration in terms of the month because we haven't seen the condition to assess it. But bear in mind, we will deliver the best of quality in terms of hygiene. Thank you. What's that?